So I'm going to be talking about emergency medicine, leaning forward. We're really going to talk about the future of emergency medicine and where we need to be in the next 5 years. It's kind of a 30,000-foot level, but if we don't start looking at getting into value-based, emergency medicine being more value-based, we're going to have legislators, the government, and the payers tell us not only trying to take patients out of our emergency department, but they're going to be telling us how to practice emergency medicine. So we really must be more proactive and look at how we can become more value-based. So what's the case for emergency medicine? Well, in the last 25 years, or last 20 years, our emergency department visits have gone up 30%. At the same time, we've lost about 25% of our emergency departments. Now, that's not quite a fair depiction because most emergency departments, if I asked people in here who have had their emergency department renovated in the last 5 or 10 years, just about all of you would raise your hands because we've all expanded. We're bigger, we're busier. But in 2009, the data, we had 136 million visits. Now, we just got, a couple weeks ago, the 2010 data, which shows our ED visits dropped to about 130 million. We're going to have to watch that because, as I said, they're going to be looking at, the government and payers are going to be looking at ways they can get patients out of your emergency department, and that's not necessarily good for emergency medicine. So I'm going to tell you some ways that we can try to improve that and maintain our business and maintain our importance in medicine. So here's the real story here, and you've all seen this, spending on healthcare. Whether it's the average spending per capita or percent of gross domestic product, that top line is the United States, and we're way above every other country. And we cannot continue this and maintain this and be an economically viable country. Right now we're at 18% of gross domestic product. That's going to go up to 20%. Medicare and Medicaid as a percent of the federal government's about 22%, going to go up to 25% in the next couple years. We have to find ways that we can reduce the growth of this. Now, I'm going to come back to this later on in my talk because there are some ways that we can look at, and I'm going to get more granular on this data. But overall, we're much higher than every other country. So in emergency medicine, we even have more of a perfect storm. Our volumes are increasing. Our revenues are going down in terms of payments from the payers. We have on-call specialty physician shortage. We have inpatient bed shortage, particularly in the critical care beds. The sequester that may or may not come, but if it comes at the end of this week, it's going to have a major effect on our volumes because community health centers are going to be taking a big hit in this. And people are not going to be able to get the care they need. Where do they go? They go to the emergency department. EMTALA, foreign nationals, are all affecting our operations at a time when our costs are going up. So this is important, and we've got to find ways, again, that we can enhance our business and be part of the value-based purchasing methodologies. So what is healthcare reform really about? It was really about 3 aspects. It was about access, quality, and cost. Access to the Accountable Care Act was we're going to provide more people with insurance. And so we'll talk about in the next couple slides the individual mandate, exchanges, expanding Medicaid. But as we know, and the experience in Massachusetts, expanding insurance does not necessarily mean that patients have access to health care. What happened in Massachusetts, primary care visits as an initial visit grew by 3 times the wait. Grew to get a specialty appointment, doubled. And ED visits went up because, again, people have insurance. They feel the entitlement to health care, but if they can't get it, they're going to go to the emergency department. It's about quality. So we've seen a lot of work on improving quality or enhancing quality metrics. The number of quality metrics have markedly increased, including customer service metrics. And it's about cost. And we'll get to that. The real driver in most of this is cost, and we're going to have to find ways to be much more efficient in what we do. Because in the future, we are not going to necessarily be measured, you will not be measured as emergency physicians solely on productivity. In fact, you're going to be measured primarily in the future on the healthcare status of the population that you're managing and your resources that you're utilizing. And you will start getting measured. Our hospital And our physicians are now getting measured down to the detail by diagnosis. And if our primary care doctors, if they're CHF patients and they get measured against a group of other similar providers, if their CHF patients are a higher cost, then we can dig down. Is it because you're ordering too many lab tests? Is it ordering too many expensive drugs or non-generic drugs? Or your length of stay, radiology utilization? This will be coming first to the primary care and hospital-based specialties, but we'll also get to our hospital employed, but we'll also get down to the emergency physician level in the future. We've got to start preparing for that. So the Accountable Care Act, 5-4 decision was affirmed. The Accountable Care Act, basically everything was affirmed except for they couldn't force the states to take federal money, but everything was affirmed in this 5-4 decision. And the individual mandate, again, if you're an insurance company, so the state and federal government are the largest insurers in this country, you want to make sure that you can spread your risk. And that's why the individual mandate's so important. Because if you only have sick people getting insurance, that insurance is expensive. And the principle of insurance is that you need to spread that risk. So you need to get healthy people into this as well. And in 2014, when most of the insurance mandates kick in, the individual mandate, the first year is only $285 per family, or 1% of income, whichever is greater. By 2016, it goes up to almost $2,100 or 2.5% of income. And the exchanges, you've heard this mentioned in several of the talks today. This really is an insurance marketplace. And there'll be federal support and a federal plan if states decide not to set up their own exchange. And also states are being asked to expand Medicaid. And basically the government's funding that for the first 2 years. After that, they'll fund about 90%. But governors are concerned, mainly Republican governors are concerned, about the expenses that will come after the first 2 years, and they also fear that the government will not be paying 90%, but will eventually lower that, and more of the costs will be transferred to the states. There's a bunch of other insurance market stabilization aspects to this legislation. Very complex legislation. Most of it's not being implemented right now, and those we can get at our regulators right now to try to figure out how these are going to get implemented and have some say in how it can get implemented in terms of its effect on emergency medicine. So Medicaid expansion. I had to go to the White House and meet with a group of other medical society leaders talking with CMS. They really want to push the medical societies and others to lead the Medicaid expansion in their states. And again, this will affect individuals at the 133% of federal poverty limit, again, starting next year. A handful of states have elected to do this. About 22 states are deciding not to or haven't made up that decision, again, due to cost concerns. Now, the American College of Emergency Physicians did work on the Accountable Care Act back in 2010, got some of our emergency care provisions into the language. Cannot require prior authorization for emergency services, must provide coverage even if those services are not provided by out-of-network providers, cannot charge higher co-pays or co-insurance for out-of-network providers. And again, one of the most important is the prudent layperson standard is included in these reforms. If the average individual feels that they have an emergency, they should have the right to go to the emergency department, and that visit should be paid for. Now again, how that gets interpreted, particularly on a state level, we keep fighting this all the time. But it's important to have this in the Accountable Care Act, the federal prudent layperson. We work very hard to get that in. So here's sort of the timeline. The PPACA or the Accountable Care Act was passed in 2010. It was affirmed by the election. The election of President Obama reaffirmed this health care reform. And as I mentioned, in 2014, most of the insurance reforms are going to go into place. The guaranteed issue, federal rating requirements, and state-based exchanges or expansion of Medicaid will start in less than 1 year. So what are some of these insurance reforms that we're going to have to look at? Well, there's the mandate. Again, we talked about the individual mandate. There's expansion of Medicaid eligibility up to 133% of the federal poverty limit. There'll be these insurance exchanges that will be set up. There are also some good things. Dependents up to age 26 can remain on their parents' policy. A guaranteed issue and renewability. Just because you develop a chronic disease while you're insured, they cannot not renew your insurance. Pre-existing conditions should not be considered in terms of getting insurance. And again, there are some essential health benefits, of which, again, emergency medicine is an essential health benefit in the Accountable Care Act. Again, based on the prudent layperson standard. But what is going to be the effect of all these insurance reforms on the emergency department? Again, if you look at the Massachusetts experience and others, we're going to see an increase in emergency department visits as these get implemented in the next couple of years. We don't have enough primary care doctors out there. The subspecialist care will also be hard to get into, although probably not as hard as primary care, a new appointment for primary care. So we will see an increase in emergency department visits. In Massachusetts, they went up 5 to 7% in the first year. They somewhat stabilized after that, but again, they've increased. We've got to be prepared for that. So what does the Accountable Care Act do? It will really insure about 32 million more Americans. About half are going to be on Medicaid, the expansion Medicaid, half in the insurance exchanges. 105 will no longer have an insurance limit on their coverage, 105 million. There will still be anywhere from 18, 19 to 27 million, depending on who you look, you listen to, that people who are still uninsured. And who are those who are in that 20 million uninsured? Which groups? Basically two big groups. Illegal aliens, okay, and the other are going to be healthy young people, the 20 to 30-year-olds who aren't on their parents' coverage. You know, insurance is expensive. They're invincible. When you're 20, in your 20s, you're invincible, and you don't think you need insurance. And that's going to be the people. And those are exactly the people insurance companies want on insurance because they don't use the insurance as much to help spread that risk out. But again, it's going to be important. There will still be in the 20 to 25 million uninsured. And this was an article, a cartoon, the Republicans, you know, Medicaid now, we already have a plan for the uninsured, and they're dumping it into the emergency department. And if you remember, there were several Republican governors that stated, including the presidential candidate, stating that we did have universal health care coverage, we had the emergency department. And we can use that. It's important. We aren't universal health care coverage, but again, we are a white hat specialty, and we need to be able to use that. So what are the accountable care effects? Payments. As we already mentioned, Medicare payments for Medicaid patients for primary care. This does not include emergency medicine. We tried, but for years and years, for 30 years, we said we were a specialty, and now we can't say we're primary care. So we didn't win this battle. I just read today in one of the daily reports, though, that there's not a single state that has implemented a policy or procedure for giving Medicare payments for Medicaid right now. The Independent Payment Advisory Board. This is an independent, right now, you get paid based on your RVUs, and your RVUs are given so many dollars. That's looked at by the RUC committee, which is really part of the AMA. It's all the specialties, and ACEP, emergency medicine, is represented at this. And every 5 years, they basically haggle it out how much your RVUs are worth. And emergency medicine is done very well. There's a concern that the procedural specialties are valued more than cognitive. That's been going on for years. But at least there is physician representation. The IPAB would be an independent board of 15 members that if they decided your RVUs were too high, that emergency medicine is getting paid too much, they could independently just decide that. And then it would be implemented unless there was an act through the legislature to reverse that. But as it is right now, it gives them a lot of authority. Now, there's also a concern that the IPAB may not, because our Medicare per capita growth rate right now is less than the Medicaid target growth rate, that the IPAB may not kick in until 2017 or later. So this may not be as big a threat as people think it could be, but if it does come into effect, if costs rise higher, IPAB kicks in under the Accountable Care Act, and they could decide what you get paid. There's delivery system reform. Accountable care organizations, bundling of payments, episodes of care. We're going to see this more and more. The ACOs, there's now over 100 that have been approved. We're going to start seeing this. The problem is, right now, there's not a model on how emergency medicine fits in to bundled payment or accountable care. There isn't a model. Right now, they're carved out. But that's not a long-term strategy. Ultimately, we will not be able to say we need a carve-out. We're going to get put into a bundled payment or an ACO, and we've got to start figuring out, it may be negotiated on a hospital-to-hospital or state-to-state basis, but we've got to start proactively thinking how we're going to fit into that rather than a reactive mode. And then quality, again, we have a lot more quality metrics out there. And how does emergency medicine fit into that? What are the emergency medicine quality metrics? Because you will get paid on that. Your hospital will get paid based on your quality metrics, based on your customer service scores, your HCAP scores. So it's important how we figure that out. There's three things that really weren't addressed well at all in the Accountable Care Act. Sustainable growth rate formula, which is how you get paid. You get paid based on the RVUs, but the SGR was a means to control the number of, or the amount of care that's done. It was a very poor metric because it wasn't tied to the health of patients, it was tied to the gross domestic product. So if health care rises more than the gross domestic product, the SGR calls for a cut in payments, in Medicare payments. And so right now, it's about a 30% cut in physician fees. Medicare. And what happens in Medicare, as you know, happens to the other payers take that on. So the SGR is a major battle right now. Was a $320 billion fix. Because healthcare costs have come down in this next year, it's less than that. It's about half of that. Might be time that we start looking at fixing the SGR. Liability reform was not really tackled at all in the Accountable Care Act. There's $50 million for demonstration projects, but that's not sufficient. We need to have liability reform. PricewaterhouseCoopers study in 2007 said there was $200 billion in waste due to defensive medicine. That is a huge cost. We need to be looking at that. And end-of-life care. What happened when we started mentioning end-of-life care in the Accountable Care Act? What was the term used? Death panels, right? Even I got a call from my dad thinking I was going to put him down. I heard after 70, they're not going to let me get hospitalized. That's not exactly it. But we need to have this conversation. I'm going to show you a slide later why we need to have this conversation. But 5% of the population spends 21% of the healthcare dollar. 20% spends 70% of the healthcare dollar. And that's usually in the last few months of life. We've got to start having this discussion. That is a huge cost to the system. And I'm going to show you later why that is. So here's the formula for value in healthcare. Value equals quality divided by cost plus service excellence. So the way to enhance value is to improve your quality, to improve your customer service, and we're doing that. And that's what your quality metrics are, your HCAP scores. But the biggest driver is going to be cost. We've got to look at reducing cost. And the only way we're going to be doing that with all the increased number of patients is become much more efficient and manage that cost, or manage those patients care. So what is the value of emergency medicine? So when, for 25 years I've been in organized emergency medicine, and when you go out and talk with your legislators, what do they think about emergency medicine? What are the negatives? I mean, they actually do get that we take care of sick people and get that, but what I've heard for 25 years, we're expensive, and we have too many unnecessary patients there. And your legislators, no matter, even some of the more enlightened ones, still think that. So we do provide a huge amount of value right now. We can reduce potentially avoidable admissions or reduce readmissions. You've heard some of the strategies for doing that. We can become the rapid diagnostic center. One of the things that I don't think we get enough credit for is reducing what's called the patient cycle time, reduce time off from work, reduce pain and anxiety. Again, if they saw their primary care doctor, the old Greg Henry or Tom Mayers, you're going to be here 6 hours for your abdominal pain, but I'm going to be able to do 10 days worth of work. Because again, they'd have to make an appointment with the primary care doctor. That takes 2-3 days. They'd go and see them. They'd order blood tests. You get the next day. CT scan, you get 2-3 days later. And then you make an appointment 3 days later to see them. We can all do that. And we get people back to work much sooner. We can reduce unnecessary testing. I'm going to be talking about that tomorrow. We provide disaster and preparation and syndromic surveillance. We can do regionalization of care. And we are, a potential interface with the value-based mainstream strategies such as accountable care organizations or episodes of care. That's a gap right now that we can really fill that I think we're going to need to. So the value of emergency care. So emergency physicians comprise 4% of all physicians. And we spend anywhere from 2 to 4% of the healthcare dollar. Now, we used to say 2%, and we used to be very proud of that. But now as we look going into an ACO and negotiating what our payment was, I'm not sure we want to say we're only 2% of your dollar. So, we're in a catch-22 right now in some ways. But we still provide tremendous value. We provide 28% of all ambulatory care visits. We provide 2/3 of under and uninsured ambulatory care visits, and we provide 70% of visits after hours. That's a huge value for just 4% of the physician workforce. We provide huge value. We always have to dispel myths that these patients don't need to be here. And this was in July, Health Systems research brief that Medicaid patients, when they come in, they do utilize the emergency department more. Why do Medicaid patients utilize the emergency department more? Okay, number one, because they got chronic disease in the adult population. That's why they're on Medicaid. In the pediatric population, it's a little bit different, but in the adult population, so they visit for more urgent symptoms. And then the Smolowitz article that came out around the same time said, the way that we can affect costs. What percent of hospital admissions now come through the emergency department? Nationwide, we went over 50% a couple years ago. We're about 55% of all hospital admissions now come through the emergency department. It didn't used to be that way. My hospital is 95%. So the way we can really affect change and reduce costs is affecting those admissions. How we can better manage those patients, keep them well, keep them out of the hospital. That's the way, not trying to prevent lower acuity patients from coming to our emergency department. That's such a small dollar amount. We have a huge impact on who gets admitted, and we need to start using that influence, that power, in how we're perceived. What I'd like to see is the emergency department as the center of the hub. We're a fixed cost. We have to be open 24 hours a day no matter what. We have to have lab, we have to have nurses, we have to have radiology. When you have a large fixed cost, you want to try to utilize that as much as possible. I'd like to see us as the center of the hub, the hub of the enterprise. We can deal with the medical home, we can deal with urgent care, the primary care doctors, nursing home, the specialists. We could help coordinate care. We have access, I already mentioned, to 130 million visits. We should use that access. Instead of being an island where we just send people and we send them out, we could be a bridge to the primary care doctor, the ambulatory setting, and the inpatient. We could be that bridge, and also to value-based purchasing methodologies. Get them into their medical home. Get them into the community health center. Start integrating that care much better. We've got to start doing that. If we don't, the payers and government are going to take patients out of our emergency department, and they're going to tell us how to practice. So, when I became president, I really tried to focus on transitions of care. You can look at transitions of care a couple of ways. One is, the transition from the emergency department to the inpatient. And we have a group working on that. How to communicate better, because there's a lot of miscommunications, and breakdown in care often occurs at that transfer. But I also want to look at the outpatient transitions of care. Again, we have access to 130 million patients, and there's probably 130 million visitors that come with that patient. Okay, that's 2/3 of the population comes through our emergency department each year. We need to use that access to look at what I call part of the medical neighborhood. Could we be doing prevention, immunization, wellness screening, disease management, chronic disease, palliative care? I'm going to talk each about these a little bit more. But I think it's imperative that we start looking at managing this patient. You've already heard some talks today. Dr. Clower talked about the high utilizer patient. You've heard about observation units. We need to look at, these are ways that we fit into a value-based purchasing methodology, how we enhance our value, because again, the real key is controlling cost. And so managing these patients more efficiently is going to be the way that we can fit into this. So if you looked at value-based healthcare through the years, we've moved from a transactional model. I see a patient, I do a procedure, I get paid for that, to a more of an episodes of care, and there's been a couple demonstration projects. The biggest ones are hip replacement and coronary artery bypass graft, but they're going to start developing more episodes of care. We're going to start moving into a condition care model where you start managing not only cancer or diabetes, asthma on a chronic disease or condition model, and we're eventually going to move into population-based healthcare, where you look at, you will be responsible for a population, and you'll get measured, as I mentioned, on the wellness, how well that population is, and how many resources they consume or don't consume. That's how you're going to get measured in the future. Productivity will always be important. Customer service, quality metrics will always be important. But we're going to be moving, the government's moving to a more population health-based model, and we've got to see how we can fit into that. So the medical home, again, medical home is great in theory. We just don't have enough medical homes, don't have enough primary care doctors out there. So we've got to look about cost-effective emergency care. Again, I'm going to talk more specifically about testing tomorrow, but other ways that we can fit in, almost 1/3 of discharged Medicare patients were hospitalized within 90 days. So now the government's not going to pay for 30-day readmissions. A lot of studies will show that we really don't have the ability to affect 30 days. We have maybe 72 hours to 7 days that we as healthcare providers can control, because once they get out, it's hard to control that. But they want to get people in to see the primary care. They want to make sure that they get their medications, that they're followed up. We can look at how can we help with that in emergency medicine. Well, one, you've already heard Jay Scher talk about observation units. Run by emergency medicine, available 24/7, separate staffing is a way that we can help reduce readmissions, potentially avoidable admissions, and reduce costs to the system. It can also be a revenue generator for your emergency department and can actually even reduce some of your nurse staffing. Now again, some of the issues we're facing on this right now that ACEP's working on, one is the co-payments for observation unit. The patient gets all these co-pays. And it can be very expensive for the patient. We're trying to get CMS to understand this and streamline their rules for this. The other is the 3-day observation, which Jay mentioned. You can't go into a nursing home unless you have a 3-day stay in a hospital. Observation doesn't count in that. We're trying to get CMS to get rid of the 3-day rule, because again, it's cost savings. We're trying to be proactive in saving money for the healthcare system. Again, care coordination is going to be the cornerstone. Again, it's the cornerstone of accountable care organizations, going to be for readmissions and episodes of care. And we have to fit into that. What I fear is you have a patient that needs to be admitted, and you've now got the hospital and the primary care doctor on the side is, we don't want you to admit them because we're not going to get paid. And you've got to be that patient advocate. Again, one way is the observation unit that we can do, but again, we've got to change some of the payment rules. So decreased cost for chronic care. I don't think that's me. My phone's over there. Decrease for chronic care. We've got to do better case management, which I'm going to talk about. But how many of you are using community paramedics now? Anybody? A couple of you. We're going to start doing this in Chattanooga, where I'm at, and using paramedics to go out and check on on patients, particularly chronic disease patients, the high utilizers that Kevin Clower were talking about. We're going to go out, CHF patients, we're going to have the paramedics weigh them. We're going to have them take their blood pressures, make sure they got their medications filled. Go out and talk with them, because sometimes there's a lot of downtime in the system. Particularly, we're going to use our supervisors, and we're going to limit it to, again, high utilizers. But a lot of communities are now using their paramedics or developing community paramedics to check on chronic patients or frequent ER users. Increased efficiency of primary care. Now the problem, we could look at doing acute, and we do acute care, but there are now emergency departments, and I just did an interview last week about emergency departments that are giving appointments in their emergency department. And so you can schedule an appointment. Again, we have those high fixed costs. We should utilize the heck out of our emergency department. Looking at primary care, we can increase the efficiency of primary care. Again, we have to have that communication, that common electronic medical record that will provide that information. But we can really enhance primary care. Now, one of the problems that we have is our payment model. We get $37 for that sore throat, and then the hospital throws a $400 facility fee on them. We've got to look at a new model of payment if we're going to do primary care in the emergency department. There are some groups that have like an urgent care and an emergency department, and they can see them in the urgent care. There's a couple groups in Minnesota I know are doing that. But we've got to look at a different model on how to do this. But we should be able to do this. Again, we've got high fixed costs. Our variable costs are not nearly what our fixed costs are. We should be using this more. Increased preventative care. This is going to be important. Immunizations, education, high-risk behavior, mental health screening. We could look at providing more preventative care. Decreased costs for chronic care. Most of you, I think, probably have increased your case managers in your emergency department. 5 years ago, we didn't have any. Now we've got more. We've got social workers. We're looking, the problem in the emergency department is you don't want to do it in the emergency department. You want to create an area around the emergency department to do this, and most of us don't have space around our emergency departments. But again, managing care in the emergency department or surrounding the emergency department. Those high-risk patients, high-cost patients, chronic illness. There are some that have a discharge center now where actually nurses call the patients the next day and make sure that make their appointment, make sure that they have transportation, make sure that they're getting their prescriptions filled. We have a huge ability to help with that. Decreased costs for chronic care. You heard Dr. Janiak talk about telemedicine. We look at daycares, prisons, nursing homes. We should be expanding the use of this. We're going to start using this for our rural emergency departments. And be a resource using telemedicine. It's going to be a growth industry. It's going to be a way that, again, we can enhance our value and decrease the cost for care. So I wanted to add the last few slides to talk about end-of-life care and how we can look at this in the emergency department. So remember the graph I showed where the U.S. was way ahead of everybody in per capita and GDP? Well, when you really look at it by age, we're exactly in line with all the other countries until about age 57. And then look what happens. We just skyrocket. So for those of you 57 here or older, I'm sorry. But we need to look at this. I'm getting there soon too. But we need to look at this. Again, other countries have figured this out. They figured it out. We need to have this discussion. So how can the emergency department be more involved? You look at disease presentation. There's curative therapy, and then there's the non-curative symptom management, which is palliative care, and then there's end-of-life care before death. We could fit in end-of-life care by doing pulse, making sure that patients have advanced directives. We should be consulting or getting patients, especially with chronic disease, in palliative care. So we're having discussions with the Palliative Care Society. We're having discussions with Society for Hospitalist Medicine on how to do this better. But we have that opportunity. Again, I'm not sure emergency medicine wants to take the lead on this because of the fear of death panels, but as a country, we need to start having this discussion, and I think emergency physicians, emergency medicine can fit into this. We're actually looking at a strategy at ACEP, starting off with education, core curriculum, a PR, implement this in our transitions of care plan and delivery system reform, and then do some advocacy efforts. So we've got a plan, but we need to start fitting into this if we're going to reduce costs. So there are some requirements for all the things I talked about. We need to talk about cost as opposed to charge-based decision-making, and I think we're going to be moving into more of a population-based health. We have to have a transparent EMR, that it connects all services. Without that, we're not going to be as efficient as we need to be. And this is a real sticking point with many health centers or many health systems, is the interconnectivity of the EMRs. It has to be data-driven. And again, we're starting to do this with our hospital employed at my hospital and my system. We're going to be looking, there's programs out there that can look at all the resources that you're consuming based on diagnosis, patient age, data-driven, and you will get measured on this in the future, I guarantee it. Again, we have to have some reimbursement for care management. Right now, emergency medicine is excluded. There is a CPT or a charge that you can do for care management, but not for emergency medicine. We need to look at fitting into that. And again, workforce requirements. What are our workforce? Again, we may not have enough emergency physicians. We've got a large group of PAs, other specialty trained that are working out in rural areas. How do they fit into emergency medicine? We've got to figure that out. So real quick, some other issues. I've already talked about some of the reimbursement, Medicaid expansion, how we fit into that, the SGR. But again, we're going to be moving away from a fee-for-service, and so how do we fit into that? Quality, we're going to look at reduced testing. I'm going to talk about cost-effective emergency care tomorrow, but again, improving the patient experience. Cost-effective emergency care and liability is going to, again, be a big issue. ACEP sort of put their money behind, giving us the protection that the public health service providers do, which means you move from civil court to federal claims court, which may or may not be great because you don't have control of it once it gets to federal claims. If we really want to change how we practice, I think we need to give safe harbors for using best practices. So, the cost-effective emergency care, the choosing wisely, if you use if you make a good faith effort in using those, that you're protected. Right now, any safe harbors you have can easily be gotten around by lawyers, but we need to, look at, in my opinion, looking at safe harbors, because that's the only way you're going to change physician behavior. Because we've trained at least 2 generations or more of physicians to order tests rather than examine the patient. And if we're going to really change physician behavior, we need to be doing that. And I'm guilty. I'm a dean. I've been in education my whole life, but we need to look at if we want to change physician practices. So anyway, I hope I've given you a little bit of an overview, and I didn't really get us back on time too much, but thank you very much for the invitation.